Hello everyone and welcome to my channel. We are starting the unit liver and biliary system. The important topics that we will be discussing in this video are given. Okay, these are hepatitis C, hepatic encephalopathy, spontaneous bacterial peritonitis, acute hepatitis, hepatitis B, hepatocellular carcinoma, Wilson's disease, and amoebic liver abscess. So the first topic that we will be discussing today is liver and biliary system is hepatitis C. Here we are having a scenario that there is a 48-year-old non-HCV positive patient presented with history of passing black color stools from last few days. Last week vomited blood on examination, ascites and palpable spleen is present. So what is the diagnosis? What are the three causes of ascites and melena and hematemesis? And enumerate therapeutic intervention to control active bleeding. Five parameters used in child and the turcotte puff scoring for this system. So we are having a definition that it results from the portosystemic strands formed where systemic and portal circulation share common capillary nodes. The clinical features are hematemesis. The causes of melena are bleeding ulcers, gastritis, esophageal varices, Michel's diverticulum, and peptic ulcers. And the causes of hematemesis are esophageal varices, gastric tumors, duodenitis, chronic liver disease, bleeding ulcer, and stomach tumors. The management options are emergency call, that is, assist the BP, pulse, and monitoring, and take output record. Then the blood transfusions are done. Intravenous crystalloids are given, for example, normal saline. Then we will correct the coagulopathy, that is, FFP transfusion is done. Esophageal balloon tamponade is used, and drug therapy is provided, that is vasopressin and octreotide. Then endoscopic sclerotherapy or bending of the varices system. Transjugular intrahepatic portosystemic shunt is used. Intravenous omeprazole or oral sucralfate to prevent stress ulcer. Prophylactic antibiotic, that is ceftriaxone and phosphate for or syrup lactulose is used to prevent encephalopathy. Then take opinion for surgery of the above major phase and the tertiary prevention by doing sclerotherapy band ligation of the varices. Now we are having this child Turcotte puff scoring system, which is a score that rates severity of the long-term liver disease. 5 parameters in this scoring system given as follow. These are factors are total bilirubin level and serum albumin level, then the PT and INR level, the ascites level, the hepatic encephalopathy, and the total points in for shows the year survival. So if the total bilirubin level is less than 34, then 1 point. If it is 34 to 50, then 2 points. And if it is greater than 50, then 3 points. Serum albumin greater than 35, 1 point. 28 to 35, 2 points. And less than 28, no 3 points. PT or INR less than 1.7, 1 point. 1.7 to 2.3, 2 points. And greater than 2.3, then 3 points. Ascites, if none, 1 point. If mild, then 2 points. And if moderate to severe, then 3 points. Hepatic encephalopathy, if none, then 1 point. If grade 1 or suppressed with medications, then 2 points. And for grade 3 and 4 or refraction, 3 points. For class A 5 to 6%, class B 7 to 9%, and class C 10 to 15%, then it is 45%. So we have discussed the topic of liver disease. We discussed the scenarios and the clinical features and the causes of melanoma and the causes of hematemesis. Then we discussed the management options and then child Turcotte puff scoring. Now coming towards the next topic, that is hepatoencephalopathy. We are having a scenario that there is a 40 years old man having hepatitis related liver cirrhosis, and he is admitted with nausea and vomiting and confusion. On examination, he is drowsy and irritable and had ascites and flapping tremors. The next scenario is that there is a 50-year-old patient HCV related chronic liver disease and abdominal discomfort is present. Nausea, confusion, ascites is present. Patient is febrile, drowsy, and palpable spleen and flattening tremors are present. So what are the diagnoses, the investigations, the complications, and the treatment options, and the causes or precipitated factors for this condition? So let's define hepatic encephalopathy. It is a neuropsychiatric syndrome caused by cirrhosis which progress from confusion to coma. The clinical features are progressive mental state deterioration, confusion, drowsiness, aggressiveness, and coma. The flapping tremors are present, and constructional hyperreflexia is present. The causes or precipitated factors of the hepatic encephalopathy are drugs, infections, electrolyte and metabolic imbalance, increased nitrogen load, that is protein, increased diet, and GI bleeding. The complications are brain herniation, brain swelling, kidney failure, sepsis, and respiratory failure. The investigation options that are done for the hepatic encephalopathy are: diagnosis of the hepatic encephalopathy is usually clinical. If acute or chronic liver disease is evident, liver biochemistry is done, that is LFTs, PT, and serum albumin. EEG is done to detect subclinical encephalopathy. Arterial blood ammonia is done. Increased level is highly suggestive of the diagnosis of hepatic encephalopathy. Then the treatment options for hepatic encephalopathy are: identify and remove the precipitating factors, then pass NG tube for feeding, then stop diuretics, correct any electrolyte imbalance, enema per rectum to relieve constipation, lactulose for laxatives is given, neomycin decrease ammonia producing bacteria from gut, rifaximin decrease bacterial content of the bowel, rifaximin, and antibiotics for infections like SBP, UTI, or pneumonia is given. Benzodiazepines for transient improvement is given, and the long-term treatment is proteins should be reduced, avoid constipation, and avoid precipitating factor. So we have discussed the hepatic encephalopathy, then we discussed the scenario, the definition, then we discuss the clinical features, what are the causes and precipitated factors, the complications, the investigation options which are clinical, and liver biochemistry, EEG, and arterial blood ammonia. Then the treatment options, that is, we have to remove the gas, pass the NG tube, stop diuretics, and the long-term treatment, that is proteins should be reduced and avoid constipation and avoid precipitating factors. Now coming towards the next topic, that is spontaneous bacterial peritonitis. We are having a scenario that there is a 45-year male suffering from HCV related chronic liver disease, ascites, abdominal pain, and fever. Clinical feature: temperature 100 degree Fahrenheit, TLC 12,500 with 85% polyps, and chest X-ray urine RE is normal. So, what are the complications, investigation, and the treatment? Enumerate other complications. In the scenario, the hints for hepatitis for spontaneous bacterial peritonitis are hepatitis C, ascites, abdominal pain, fever, and leukocytosis. Another scenario is that there is a 45-year-old male suffering from chronic liver disease, ascites, abdomen, and fever. On examination, he is febrile. Lab investigation: TLC with 85%, chest X-ray, urine RE is normal. So, what is the diagnosis, the investigation, and the treatment? It is a serious complications of the ascites with cirrhosis, and the clinical features of the spontaneous bacterial peritonitis is that it is the sudden onset of abdominal pain, rebound tenderness, and absurd bowel sounds, and fever is present, and the signs of cirrhosis and ascites are there. The investigation options for spontaneous bacterial peritonitis are: ascitic fluid RE, or diagnostic practice may show the an ascitic neutrophilic count is increased. Ultrasound abdomen is an ascitic fluid culture. In blood culture, inoculated at the patient's bedside gives highest yield of the organisms. Okay, now the treatment options are: immediate start with broad spectrum antibiotics such as cephaloxime and penicillin. Then the diuretics for ascites, for example, furosemide, and therapeutic ascites step with albumin support is given. The prevention of spontaneous bacterial peritonitis is prophylactically norfloxacin and ciprofloxacin are given to prevent the recurrence, and the complications are cirrhosis, ascites, hepatic encephalopathy, renal failure, and portal hypertension and death. So we have discussed the topic spontaneous bacterial peritonitis, its scenario, then the clinical features, then the investigations, then the treatment options, then the prevention, and then the complications. Coming towards the next topic, that is acute hepatitis. We are having a scenario that there is a group of college friends who had gone on a holiday to Swat and had unhygienic food at restaurant. Two friends came to OPD with anorexia, nausea, vomiting, and jaundice, and tender in right hypochondrium. FBC, blood urea, and serum creatinine were normal. Another scenario is that hepatitis A, most common type of viral hepatitis, highly infection Okay, the definition is that it is the diagnosis is hepatitis A, and the definition of hepatitis A is that it is the most common type of viral hepatitis, highly infectious, and is caused by hepatitis A virus. Diseases commonly affect child and young adults, mainly spread through a fecal route and arises from ingestion of contaminated water and food. Investigations are LFT tests, ALT and bilirubin will be raised, hepatitis B surface antigen, anti-HCV antibody to rule out the hepatitis B C, viral hepatitis serology for A, B, C, D, and E virus, and serum electrolyte. Ultrasound abdomen is done to exclude the obstruction, FBC is done for anemia, and PT is done for assessment of the severity. The treatment options for acute hepatitis are bed rest, increased fluid intake, soft food diet, antiemetics, intravenous infusions, antipyretics, follow up with LFTs and PT, and liver toxicity. Okay, the specific treatments are antiviral are not routinely indicated, liver transplant rarely indicated for acute viral hepatitis. The supportive measures are prevention, proper hygiene, hand washing, improved sanitation, safety measures for food item, and specific vaccination against hepatitis A and E. Complications are hepatic encephalopathy, acute liver failure, and coagulopathy. So we have discussed the topic hepatitis A, that in which cases it occurs and what are the clinical features and the diagnostic points. Then we discuss the definition of the hepatitis A, then the investigation options, which are LFTs, hepatitis B, surface antigen, anti-HCV antibody, viral hepatitis serology, ultrasound, FBC, and PT. Then we discuss the treatment options, which are general measures, then the specific measures, then the supportive measures, and then we discuss the complications of the hepatitis A. Now coming towards the hepatitis B. We are having a scenario that there is a 35-year-old married laboratory technician who is having chronic hepatitis B, came to a hepatologist. He is worried about his condition and wants to be treated. What are the investigations options? What are the two drugs available for treatment, and how you will counsel the patient? So the investigation for hepatitis B are HBsAg and anti-HBc IgM. If HBsAg is positive, then a full viral profile is performed. HBV DNA PCR is the most sensitive test. Other investigations that are done for hepatitis B are LFTs, raised ALT, raised AST, and bilirubin, which is usually normal. Ultrasound abdomen is done, CBC is done, liver biopsy is done, and PT normal until cirrhosis. The treatment options for hepatitis B are interferon alpha 2B and lamivudine, adifovir, and liver transplant. The counseling for hepatitis B patients are educate the patient about the disease, encourage hydration, precautionary measures related to sexual activity, use of condoms, etc. Thorough sharing food is not contraindicated, blood sharing contraindicated, encourage treatment and timely medication, lab test, etc. So we have discussed the topic of hepatitis B, the investigation options that are done for it, and what are the other investigations, then the treatment options, and then the counseling of the patient. Now coming towards the hepatocellular carcinoma. We are having a scenario that there is a 55-year-old man having HCV related chronic liver disease, complaints of ascites, abdominal pain, anorexia, weight loss, no hematemesis or melena. On examination, BP is 120/80, temperature 100 degrees C, jaundice is positive. On abdominal examination, tender mass in the right hypochondrium is present. LFTs, bilirubin 3.5 mg, alkaline phosphatase is 1000. So what are the complications, the investigations, the treatment, and enumerate the complications. The investigations that are done for hepatocellular carcinoma are alpha fetoprotein, which is raised in 60% cases, LFTs, ALP is raised, and GGT gamma glutamyl transferase. Ultrasound and CT scan is done to localize the tumor, MRI is done, and liver biopsy is done. The treatment options are non-cirrhotic patient. For non-cirrhotic patient, hepatic resection is best. For cirrhotic patient, liver transplantation is best. For tumor less than or equal to 3 cm, percutaneous ablation with ethanol injection into the tumor is done. For cirrhotic patients with unresectable tumor, hepatic artery embolization with gel form and adriamycin is done. The complications of hepatocellular carcinoma are GI bleeding, encephalopathy, weight loss, and portal vein thrombosis. So we have discussed the topic of hepatocellular carcinoma, the scenario, then its investigation, then the treatment options, and then the complications. Now coming towards the Wilson disease, we are having a scenario that there is a 22-year-old girl presented to medical OPD, complains of yellow discoloration of the sclera, tremors, and The symptoms are from last 6 months. Investigations show the raised serum and serum glucose SGPT levels, HbSAg and anti-HCV-AB is negative. Another scenario is that there are chief complaints of involuntary movements, yellow discoloration of the eyes on examinations, jaundice with tremors and rigidity is present. Abdominal examination shows ascites and hepatosplenomegaly. So, what are the diagnoses, the investigations, the complications, and the treatment? The definition of Wilson's disease is that it is also called hepatolenticular degeneration and it is a genetic disorder of copper metabolism resulting in accumulation of toxic levels of the copper. The clinical features are age 5 to 45 years, hepatitis, and brownish discoloration of the eyes, grayish brownish discoloration of the eye. 66 to 99% cases are neurological diseases, depression, delusions, Parkinsonism, dementia, and movement disorder, that is tremors. The investigations that are done for in Wilson's disease are serum ceruloplasmin, that is decreased level of ceruloplasmin will be there 24 or urinary copper, that is increased excretion. Serum copper, it will be decreased as it is deposit in tissues, but it may be normal as well. Liver biopsy is done, which is increase in hepatic copper content, and confirmatory test is 24 or urinary copper excretion while giving penicillinamine. Okay, the hepatocellular copper is decreased content and the liver biopsy is done. The treatment are general treatment, which is the restriction of dietary copper. Liver, chocolates, nuts, legumes and are rich in copper. Oral penicillin is given, which is a drug of choice, and it is a copper binding agent. Then 29 dihydrochloride are given if patient develop resistance against oral penicillin, and zinc acetate is given. It inhibits copper reabsorption in intestine. Ammonium tetrathrombolydate is given. Liver transplant is done in case of fulminant hepatic failure or end-stage cirrhosis. The complications are cirrhosis, hepatitis, anemia, chorea, muscle atrophy, and disorders of the spleen. Okay, now coming towards the last topic, that is amoebic liver abscess. We are having a scenario that there is a young man who is 3 weeks, who having 3 weeks history of dysentery, lower abdominal pain since 1 week, and high grade fever, swinging, sweating, cough, and pain in the right shoulder. On examination, temperature is 103 degree Fahrenheit, and abdominal examination shows tender hepatomegaly. So, the diagnosis, investigation, and treatment. Definition of amoebic liver abscess is that it is the most common extraintestinal manifestation of the amoebiasis, which occurs when trophozoite enters portal venous circulation by burrowing through large bowel mucosa. The clinical features are right upper quadrant abdominal pain, pain radiating to the right shoulder, and tender hepatomegaly. Then the toxicity, high swinging for single abscess, and no jaundice. Investigation options are CBC, that is increased neutrophil and leukocytosis, stool diary, that is amoeba may be present, X-ray chest, that is raised right hemidiaphragm, ultrasound visualize liver abscess, it is investigation of choice and show abscess, CT scan if ultrasound fail, or MRI. And aspiration of the fluid is done. The treatment options for liver abscess, amoebic liver abscess, are metronidazole 800 mg 8 or orally 400 days, and aspiration of the liver abscess. If medical treatment fails, antipyretic for fever are given, fluid for dehydration are given, antibiotic ciprofloxacin 500 mg are given, and diloxamine are given for the case of amoebic liver abscess. These are tape entamazole. And complications of abscess are rupture into peritoneum and structure of the thorax, abscess eroding into nearby structures, secondary infection, liver failure, and hemophilia. So we have discussed the unit of amoebic and liver abscess. We have discussed the hepatobiliary system. The following topics are covered in this video. These are hepatitis C, hepatitis C, hepatic encephalopathy, spontaneous bacterial peritonitis, then acute hepatitis, hepatitis B, hepatocellular carcinoma, Wilson's disease, and amoebic liver abscess. In the next video, we will discuss our next chapter, that is infectious disease. Thank you.